Hello everyone, I'm Dr. Monica. Today's video will be on 2017 World Workshop Classification System for Periodontal and Peri-Implant Diseases and Conditions. So let's understand the classification. So why was this new classification introduced? So the 2017 classification, it was introduced to address the limitations of the 1999 classification. In the previous classification, periodontitis was studied under two forms, that is chronic and aggressive forms. But studies show that these were not two different entities but variations of the same disease. So in the 2017 classifications, the two forms have been combined under one category, that is periodontitis, and in this system staging and grading of periodontitis is done to better describe the disease severity, complexity and the risk of progression. So new terminology changes in this classification include: first one is the periodontal biotype, which is now known as periodontal phenotype, which better describes gingival thickness, keratinized tissue width and the morphology. Second one is gingival abscess and pericoronal abscess. Now these two terms are studied under one term, that is periodontal abscess, as they share similar pathogenesis. Third one is biological width, which is now known as supracrestal attached tissues, which refers to the combined junctional epithelium and connective tissue attachment above the alveolar bone. So let's understand the 2017 classification. It is categorized into four broad categories. The first category is periodontal health and gingival diseases. Second is periodontitis. Third is other conditions affecting periodontium. And fourth one is peri-implant diseases and conditions. So let's understand the first category, that is periodontal health and gingival diseases. It is divided into three conditions based on absence or presence of inflammation, dental biofilm and attachment loss. So the first condition here is periodontal health and gingival health on intact or reduced periodontium. So what do we mean by intact periodontium? In this, there is absence of bleeding on probing, erythema and edema, and there is no attachment and bone loss. Whereas the reduced periodontium, in this there is absence of bleeding on probing and edema, but there is presence of attachment and bone loss. So reduced periodontium, it is mainly seen in patients with a previous history of periodontitis. So coming to the dental biofilm induced gingivitis, in this gingivitis is mainly caused by the presence of dental plaque. The third condition is non-dental biofilm induced gingival diseases. In this, plaque is not the main causative agent of gingival disease, but gingival diseases can be induced by genetic diseases, systemic diseases, infection, they can be allergic reactions, or any kind of dental trauma can lead to gingival diseases. So let's understand the second category, that is periodontitis. It is subdivided into three categories, that is necrotizing periodontitis, periodontitis as a manifestation of systemic disease and periodontitis. The first category, necrotizing periodontitis, it comprises of necrotizing gingivitis, necrotizing periodontitis and necrotizing stomatitis. The second category, periodontitis as a manifestation of systemic disease, it occurs secondary to an underlying systemic disease, for example, presence of diabetes mellitus, hematologic disorders, or immunodeficiencies that can impair the host immune response and increase the susceptibility to periodontal disease. The third category, periodontitis, it is staged and graded depending on the presence or absence of risk factors, bone and attachment loss. So this classification, it has categorized periodontitis into various stages. That is, stage 1 here is initial, stage 2 is moderate, stage 3 is severe with potential for tooth loss, stage 4 is advanced with potential for dentition loss. Staging is done mainly based on attachment and bone loss, whereas grading is done based on disease susceptibility, where grade A is low risk, grade B is moderate risk and grade C is high risk. So let's understand the staging of periodontitis. Periodontitis, it is categorized into four stages based upon severity of disease and complexity of treatment. So in the severity of disease, we have three factors to consider. First one is interdental clinical attachment loss at the site of greatest loss. Second one is radiographic bone loss. And the third one is tooth loss due to periodontitis. In the complexity, we look for local anatomic or clinical factors. So coming to stage 1, that is initial periodontitis. In this, there is interdental clinical attachment loss of 1 to 2 mm, and the radiographic bone loss in the coronal third, it is less than 15% of the root length, and there is no loss present due to periodontitis. And we can see that only mostly horizontal bone loss is present with a maximum probing depth which is less than 4 mm. So coming to stage 2, which is moderate periodontitis, we can see that the cal is 3 to 4 mm, and the radiographic bone loss in the coronal third varies between 15% to 33%, and there is no tooth loss similar to the stage 1 due to periodontitis. Here also we can see that mostly horizontal bone loss is present, but the maximum probing depth, it increases to 5 mm, that is it is equal to or less than 5 mm in this stage. So coming to the third stage, in this we can see that interdental clinical attachment loss, it is greater than 5 mm, and the radiographic bone loss, it extends to the middle or the apical third of the root. And there in the tooth loss we can see that tooth loss, it is less than 4 teeth, that is due to periodontitis. And we can see that there is class 2 or class 3 furcation involvement with a vertical bone loss greater than 3 mm, and probing depth, it is greater than 6 mm, and we can see moderate ridge defect in this stage. So coming to the stage 4, in this is similar to stage 3, along with the tooth loss is greater than 5 due to periodontitis, and we can see there is severe bone loss compromising the remaining teeth with a presence of less than 20 remaining teeth. There is bite collapse, drifting, flaring, and we can see severe ridge defect. There is secondary occlusal trauma and masticatory dysfunction. So the easiest way to look if the patient is in stage 2 or stage 3 periodontitis is to check for the presence of tooth loss due to periodontitis or absence of tooth loss due to periodontitis. And the other factor is to look for presence of vertical bone loss as seen in stage 3 and absence of vertical bone loss in stage 2. And to check if the patient is in stage 3 and stage 4, we can directly check the number of tooth loss due to periodontitis, first thing. Second, we can go for the number of remaining tooth loss, which can easily differentiate stage 3 and stage 4 at initial stage. So coming to the extent and distribution for each stage, it can be either localized in cases where less than 30% of the teeth are involved, it can be generalized if more than 30% of the teeth are involved, or it can be either molar or incision pattern. So let's understand the grading of periodontitis. We have three grades. Grade A, which is slow rate of progression, grade B, which is moderate rate of progression, and grade C is rapid rate of progression. So grading is done to assess the rate of disease progression and the risk of future breakdown. So now let's check the grade A, which is slow rate of progression. Here we can see that there is no evidence of radiographic bone loss over the 5 years, and the ratio of percentage of bone loss to age, it is less than 0.25. And we can see case phenotype, there is presence of heavy biofilm deposits with minimal level of destruction. And we can see that the patient has no risk factors, that is the patient is non-smoker and does not have diabetes. So coming to grade B, that is moderate rate of progression, we can see that the longitudinal data, that is the radiographic bone loss, it is less than 2 mm over 5 years, whereas the percentage of bone loss to age ratio, it is between 0.25 to 1. And we can see that the level of destruction, it almost matches the biofilm deposit level. Coming to the grade modifiers, we can see that the patient is a smoker with less than 10 cigarettes per day, and the patient is diabetic but it is under control with HbA1c less than 7%. Coming to grade C, that is rapid rate of progression, we can see that the radiographic bone loss, it is greater than 2 over 5 years, and the ratio of percentage of bone loss to age, it is greater than 1, and periodontal destruction, it exceeds the given biofilm deposits. Coming to the grade modifiers, the patient is smoker with greater than history of 10 cigarettes smoking per day, and patient is diabetic which is uncontrolled, and HbA1c is greater than 7%. So to easily grade periodontitis, firstly we look for direct evidence of bone loss. Secondly, we can look for percentage of bone loss to age ratio. And in cases when the direct evidence and indirect evidence and they are not present, we can check for the presence of risk factors such as smoking and diabetes. So coming to the third category, that is other conditions affecting periodontium. The first one is systemic diseases or conditions such as diabetes mellitus, immunodeficiencies or genetic disorders that can impair the host response and contribute to periodontal tissue breakdown. The second one is periodontal abscesses and endodontic periodontal lesions, which firstly affect the pulp and can then lead to periodontal breakdown. The third one is mucogingival deformities and conditions. In this, presence of gingival recession or inadequate attached gingiva can affect the periodontium. Fourth one is traumatic occlusion forces that results from abnormal tooth contact, and it can contribute to attachment loss in the presence of inflammation. Fifth one is tooth and prosthesis related factors. So presence of overhanging restorations or poorly contoured crowns can lead to plaque retentive areas and then further cause the destruction of the periodontium. So let's understand the fourth category, that is peri-implant diseases and conditions which refer to the health and disease states of tissue surrounding the dental implants. So this category, it is divided into four conditions. The first one is peri-implant health. In this, there is no inflammation, no bleeding on probing, and there is no bone loss. Coming to the second condition, that is peri-implant mucositis. So this is mainly caused by dental plaque, but the inflammation, it can be reversed back and there is no bone loss in this. So the third condition is peri-implantitis. In this, there is inflammation, bleeding, increased probing depth, and progressive bone loss. The fourth condition is peri-implant soft and hard tissue deficiencies. In this, we can see anatomical defects in the supporting structures, which affects the function in aesthetics, and these are not always inflammatory. If you have liked the content, please like, share, and subscribe to this channel. Thank you.